years ago when I was an undergrad, and I worked at the student health insurance office. And I had the opportunity to meet with the underwriters for the student health insurance. And I asked them something like, what is your goal in health insurance? Like, what's your purpose? And the executive I spoke to, he said, our goal is to make as much money as possible and to spend as little money as possible. And he said it just like that. And I was a little taken aback because I was just shocked by the level of comfort he had saying that out loud to me, as if he thought that this would never go anywhere. It would be completely inconsequential.
Welcome to the Only Healthcare Podcast. Today we're focusing on the consumer who can be looked at as the patient or member of a plan and really has a big role to play within the U.S. healthcare delivery system. And today we have a special guest with us from Urban Health Today, Tamara Thomas. So Tamara, do you want to introduce yourself and tell us a little bit about what you do?
Hi, so I'm Tamara Thomas, editor-in-chief of Urban Health Today and Well Woman Today, and I'm just excited to be here with you guys. What I do over at Urban Health Today is help come up with topics, curate topics surrounding how the urban professional can stay informed and better provide services for their populations. And that's the goal is to reach an audience that is super busy, doesn't have the time to digest the research the way, say, specialists would. Our focus is really on the touchstone providers. So that would be the primary care providers, your PAs, your NPs, your RNs, your pediatricians, your gynecologists. These are the providers that first come in contact with the patient population before they even get to the different specialties. And so we try to create content for them that is easy to digest and that keeps them informed so that they can be their best selves for their patients.
So the first area that we can start talking about, and both Michael and I can bring in some of our other activities that we're involved in helping to make things better and more patient accessible in particular, is that the issue of the provider shortage. And since you just mentioned a lot about that first line provider and what happens, let's get right into it, dive into the topic of shortages, which has been coming up a lot lately. It's only looking to get worse as a lot of the current older providers age out and want to retire. So, what have you been seeing since this is really your day to day, Tamara?
Well, I don't know if this is my day to day, but I know that we're facing a physician shortage by the year 2036, either through retirement because the majority of them are aging out, or burnout, or just deciding to go into other areas where we're losing physicians, and patients unfortunately are going to catch the brunt of this. And so what do we do? What do we do? What are ways that we can bring physicians back? There's also, the concierge medicine, functional medicine doctors. Those providers are sort of way out of the reach, I think, of the average consumer because they just don't have that kind of money. And a lot of them don't necessarily take insurance.
Our point of view on this, from my perspective, is that it's really a root cause issue, right? So you can go into school to be a plumber and have 6 months of a trade school and come out of there with no debt and go make a bunch of money, right? To go to be a doctor, you have to you're staying in school for 8 to 10 years. You're coming out with $500,000 worth of loans, and you're making suboptimal money, right? Because the way reimbursement has now been shifted in a lot of ways, the incentives are not really there for the providers, right? So what you've seen in the last 10 years, and I don't have any statistics in front of me, but what you've seen is this huge consolidation of networks being absorbed by corporations, the rolling up providers into their system. Then the provider is now an employee, so They're just operating as a day-to-day employee. Doesn't mean they don't care about their patients. It's just a different way of running an individual practice to running, being an employee of a larger health system that then has metrics that they're requiring you to do that may not fall into your practice strategy, right? You have to learn a whole new way. It all comes down to dollars, right? So from our perspective, there's a couple things. One is the way money is moving in the system has to be changed because patients are being disincentivized, providers are being disincentivized, manufacturers of drugs and devices, quite frankly, are getting disincentivized, and hospitals. But the people that are making the most money are the health plans. So how is it that Cignet and United make so much more money in their pockets? In the PBMs, right? They put more money in their pockets than anybody else does, and they do nothing but move patients from one thing to the next. So the money's there. So the money is there for doctors to make good money. It's being taken by health plans and it's being taken by PBMs. And so that's where there's such a major perverse incentive in the system to not go see your doctor, to not, spend money on drugs because you're avoiding all those things because you don't want to pay. And that's one of the big issues we see.
So, how did the insurance industry become so powerful?
It's fear because when I talk to employers who are you know this, so there's employers who are self-funding their benefits, there's employers who have fully funded benefits where they're just paying a premium, and there's employers who are in between, right, where there's level funding and different types of benefits, right? The fear is if you're a self-funded employer, oh my god, if an employee gets cancer, I'm going to go bankrupt. Like how do I pay for somebody who has $1 million cancer treatment? That's the fear. But that's not the reality, right? Because what's happened is insurance is no longer insurance. It is literally every service a doctor does is now being paid for by an insurance company. So whether you're going for a cough and cold visit or just a wellness visit, that money gets transferred from the insurance company to the doctor, right? There's a billing process that happens. So the most basic services that a patient should be able to go and buy themselves and pay for themselves and actually have tools to negotiate with a doctor themselves, like a menu, right? What does something cost? Has been put into the hands of these health plans who are making money off of those services. And so because they're touching every service, they're making the most money. So that's how they're powerful. So it's fear, and it's also process, and you have to go through this to get insurance. At the same time, they've also put on large amounts of deductibles. So before you even see that insurance, you have to pay insurance-based pricing to get to your deductible. And insurance-based pricing, as we all know, is fake. It's all inflated and fake, and it doesn't get reimbursed to the doctor. So we have a tool that we price out every single procedure, every single touch point based on claims data, actual paid claims. So for example, if I look up an MRI in my zip code within a 25-mile or 50-mile radius of where I live, I'm going to see 60 different prices for that MRI. But people don't know that because they haven't been educated, nor have they been given the resources to understand what things should cost. So because of the CAA laws that were passed in 2020, which those laws, if anybody's not familiar, it's the Consolidated Appropriations Act, which was put into place in the first Trump administration to start curbing these costs and start creating transparency. Now those laws are now being implemented, and you're starting to see major technologies being created so that patients can actually see what should something cost. It's kind of like talking to somebody the other day about you go to a restaurant and you sit down at the restaurant, you open the menu, there's no prices. How do you possibly order a meal if you don't know what it costs?
That's so interesting that you said that because, I was giving this some thought and I said, you know what? I'm going to do a little bit of research here. I want to see since 2021 how much allegedly easier it is to find prices as a patient. So I went on a few, I'm not going to name them, but I went on a few different New York major hospital websites. And each one of them talked about transparency. But when I downloaded the files, you can't read it. So I put it into Excel. I'm like, okay, let me see if I put it into Excel what I'm going to see. I couldn't make head or tail of that information. So how exactly are we getting this transparency? Please tell me.
Yeah, so there are companies out there. Peak is my company. Peak is one of them that provides transparent pricing for both prescriptions and physician services. We sell those. We sell that technology to employers and to consultants and brokers to use with their clients because it's necessary. But oddly enough, it's not something that's taking off, right? Because you still have the influence of the insurance companies, basically over these employers, saying, "Look, if you work with outside technologies, then we're not going to work with you," right? And so there's some again fear gets played into the system. So there's a company that we linked up with that is they do machine readable files. Like they take those machine readable files and make it consumable. Then our company then makes that even more consumable. So our technologies are very easy for patients to use. And you just type in the procedure and it tells you what it costs and it tells you which facility. It tells you the quality of the facility, so they're rated based on quality of care as well. So you can search the pricing based on that. And yeah, so I actually did this the other day. My daughter had an EEG 3 months ago for $4,000, and they never told her the price. They sent her a bill. They didn't bill her insurance, but she didn't meet her deductible, so that's fine. However, when I called them and said, "This is absurd. Here are the prices in this zip code for this procedure," and I ended up getting it down to $800 because those are the prices.
Well, yeah, that's the thing. That there has to be a way to get that to the average person so that they can access that information and they can also fight, with the insurance and with the provider and say, like I do that all the time. Providers try to balance bill me, and then you say those magic words. You're not supposed to do this. It's not legal, and then the bill disappears. But how many people know to do that, right? How many people know that that's their right to do?
You said this earlier, navigators, people that can help you, advocates, are really important in all of this because, you might think, oh, I have diabetes and I need someone to help me with my diet, my exercise, my, pharmaceutical regimen, whatever. But there's also the financial part of it, right? Which is if I'm going to take on everybody takes on financial responsibility. It doesn't just fall onto the health plan, right? So the day you sign up to work for an employer and you sign up for your health plan, you're taking on the financial responsibility for yourself. So why shouldn't you, as the consumer, be armed, right, with all this information so that you can make better decisions? No one's going to make them for you, right? So it's really important that people have this information.
Yeah, this whole issue of trying to access or shop for care that you're talking about really requires the consumer who's a member of a plan, or if they're not a member of a plan, they have to get engaged and they're going to have to learn. But they also need to know about there are some solutions out there now as technology has been rapidly expanding and beginning to address these gaps in information. So, like what you're doing, Michael, is a good example. And we're seeing that also with virtual care because of the problem with just basic access to care, particularly in rural areas, which is still in development to solve. In the meantime, there are some technologies out there to help fill those gaps so that there is some access to a medical professional. It may not be a physician, it may be a nurse practitioner, a physician assistant. There's also efforts now to look at other healthcare professionals that may be out there, like pharmacists working in local pharmacies, things like that, even dietitians, physical therapists. So, a lot of the allied health professionals that we talk about are beginning to also get more engaged in some of these as solutions to the access and the shopping aspect of this. How do I get to care? How easy is it to access that care? We were talking before we started about how far away is some of this care that we may have to drive to is another barrier. So there's lots of barriers. This information gap that Michael was talking about is real for a variety of reasons, and that's creating problems and pressure in the system because the costs keep going up every year. So it's becoming regularly high increases that employers are looking at in terms of purchasing benefits for their members of the plan, which are the patients. And a lot of that trickles down to the consumer, who's the patient. So this is becoming a problem that we need to figure out how do we stop that and bring in other ways to solve the problem and start focusing more on the solutions and get it out there and educate the consumer more about these solutions.
If I'm not mistaken, hasn't insurance started rolling back coverage for virtual visits? It was pretty big during the pandemic, obviously, for for obvious reasons. But they've recently started rolling back coverage for virtual care. No.
There's quality metrics. So I'm not saying that they don't have quality standards, but it's profitability. So if they can make money by sending somebody to virtual care, they're gonna promote it. If they're not making money, then maybe they're not going to promote it. So I think that's the unfortunate part, right? The country always creates new technologies based on need, right? So you come up with these telehealth companies, they weren't around 5 or 7 or 8 years ago, really, right? Now they've boomed because of need, demand, the pandemic, unfortunately. So innovators create the stuff and then try to help with a solution, and then once you start getting insurance companies involved, they mess it up, and because it doesn't suit them, and then everybody still thinks, oh, I need to have an insurance company, and I mean, people have to start thinking differently because they're wasting so much money having health insurance.
Yeah, I think healthcare is unique versus a lot of traditional manufacturing industries, but it still boils down to there's a financial component which Michael's talking about that's very real, but there's also the outcomes result, or have we made the patient better? Have we addressed the consumer problem? And what was being found more and more is that these virtual visits weren't really providing better care or even standard care in some cases. So, and the lack of consistency. And so there's been a lot of roll ups as well. So you may have had 10 or 20 different virtual care companies, and now they've been rolled up. Also, hospitals have taken over a lot of that. So as they become healthcare systems, they've created a virtual component to their practice. So another area of shortage is mental health professionals, which has been going on for decades now. And what they're finding is it's not so much the technology or the basic strategy. It's okay, if you have somebody who's really in a serious mental state that needs attention, there's not enough healthcare professionals. The healthcare professionals themselves, ironically, are blocking access to some of these technologies that could help, particularly on the front end for triage and trying to identify what the problems are and determining how the patient can best benefit from some kind of a mental health intervention, because there's several different ways you can address it because everybody's different. Everybody reacts differently to one-to-one care or to group care or to virtual care. And so one size fits all really didn't turn out to be beneficial from a virtual perspective. And as Michael was saying, who's making money off of this was part of the problem. But we have to really face the facts that in some of these healthcare professions where there's a specialty training involved and certifications, they have the ability to block others from entering into that market space. So in the mental health area, psychiatrists, psychologists were blocking access through either state regulations or state laws to prevent broader access to virtual care.
You mean their lobbying groups?
Yeah, they lobby against it. And so they're making the shortage worse because you can't mitigate it. It's a problem that you got to get everybody around the table to really talk this through and say, let's get real. Because as Michael said earlier, if physicians aren't making enough money, they want to make more money, but then it costs a lot to go to school. And it's this circle that we're in right now is not good for anybody.
But all the people that matter are being disincentivized. All the people that matter: the patient, the doctor, there's no incentive, right? So that's the challenge, right? They don't even want to seek treatment because it's like, well, I gotta drive, or I have to pay more money, or I have to, they're just going to give me a drug to take anyway, and I don't want to take the drug. Like, so it just, it's a really vicious cycle of that. And I think you made this point earlier. The most important people are the ones being negatively impacted.
It's funny. I remember years ago when I was an undergrad, and I worked the student health insurance office, and I had the opportunity to meet with the underwriters for the student health insurance. And I asked them something like, "What is your goal in health insurance? Like, what's your purpose?" And the executive I spoke to, he said, "Our goal is to make as much money as possible and to spend as little money as possible." And he said it just like that. And I was a little taken aback because I was just shocked by the level of comfort he had saying that out loud to me, as if he thought that this would never go anywhere. It would be completely inconsequential. But yeah, that's the secret. The secret is frustrate the system to the point that it just pushes people out, it pushes providers out, and the bulk of the pie stays with the insurance, unfortunately, which is not really how it's supposed to work. Insurance is supposed to be, who is it? Chris Rock made the joke. He said insurance is supposed to be just in case stuff happens.
And you look at it, healthcare today is really become catastrophic care coverage, and everything else is you get nickel and dime to death.
Yeah, I mean, I bet you people wish they could buy that because they're spending $2,000 a month. You have a $5,000 deductible for a family, and then you're like, and then now it's 2,200 a month the next year, and you didn't even use it, right? You might not even use any insurance. So why not just put that money in an HSA, let it grow tax free, and use tools out there to be able to do shopping, right? Have a relationship with your care navigator and your primary care and your pharmacist. And I mean, and then you have money in the bank for healthcare. It's your money, right? You earn it every month. Why give it to an insurance company who's not going to do anything with it?
Well, how do we get out of that system?
Well, I'm not an insurance broker, but I know the space. There are many people out there. We had a great meeting recently with Health Rosetta and their CEO, and they're doing all of that, right? They're helping employers break that chain and put together strategies to help them do exactly what I was just saying. And there's all kinds of solutions in there. I'm speaking very high level here, but at the end of the day, that's what it should be: is the money should stay in your pocket. It should be in an account for you to protect yourself for down the road, whatever you need. But also, if anything catastrophic happens, you have some level of insurance, like your Chris Rock point, just in case, right? There's some catastrophic coverage that if you do have something, God forbid, $50,000, $100,000 claim, then you're covered, right? You're not going to lose your house, right? And so that's how we have to change. It's almost thinking about, like, if you think about retirement 30 years ago, it was get it. If you're going to get retirement, you better get a 401k. Otherwise, you're never going to get retirement, right? So the 401k. Then with college, it was 529s, right? So now you really need to think about healthcare and think about it just like you think about those solutions, right? So save it just like you save for 401k and college. Have it there for when you need it, and break up with those health plans. I mean, they don't do you any favors.
Speaking of health plans, so let's talk about managed care for a second. Can I tell you guys a story about something that happened to me years ago? My mother passed away. She had metastatic breast cancer. And she had Medicaid, and it was managed care. I won't say the company who was managing it, but she lost she lost the ability to speak. She lost the ability. She became an invalid. And I found myself on the phone every day as her caregiver, talking to this managed care and saying, "Look, she's an invalid. She needs care. She needs an aid. She needs a wheelchair. She needs a Hoyer lift. She needs a bed. She needs all these things." And they gave me such a hard time to pay for anything. It was absolutely a nightmare. So social worker at the hospital took pity on me, and she told me that there was a way that I could petition Medicaid to remove the managed care. And then once, I sent them like a really impassioned letter and explained to them everything that was happening. And we finally got the managed care portion of the insurance removed. And then that's when the floodgates opened and everything started being paid for. But this is the kind of reality that a lot of people are dealing with.
So even that is a really great example. I'm sorry about your mom, and but yeah, it's always hard to go through that, right? And but it's almost like you need almost a health plan or Medicaid, Medicare, whatever you have, annual checkup. Like have an expert help you say what am I doing right? What am I doing wrong? Because you hear things like with Medicare, right? There's all these different plans, and there's like a Medicare Advantage plan, and I hear from people that's like the worst plan you could have, but it sounds good because it says Medicare Advantage, right? So what are the bugaboos about that aren't good, and what are good, and people don't know. So there needs to be education around all of that, and you should probably, because it's the single most annual investment you're making probably every year other than your house, you should probably have somebody looking at that for you, right? What do I have? How does it benefit me? Is there other options? And there's really no service to do that.
Well, there are some services around the Medicare, but it's you're back to the broker scenario. The other thing is the way Medicare is structured. It goes by your zip code and also your metropolitan statistical area (MSA). So you could have a plan in Florida, in Orlando, and you could be in Tallahassee, and it's totally different. Same thing if you're in Columbia, South Carolina, it could be totally different from Greenville, South Carolina. And so that's one of the issues. And to both of your points, it gets back to consumers have got to really start looking around, educating, do the checkup, like you said, and start looking at these things more critically. And the same thing for those that are working in your employer health plan, or if you're buying something through some other commercial insurance plan for healthcare, same thing. Things change every year. A lot is going to be changing for 2026 as well with some of the recent legislation. And just to kind of go back to the general insurance conversation, health savings accounts really address a lot of these issues that we're talking about, yet nobody uses HSAs. There's other similar types of programs out there that allows you to better manage, but it requires you as the patient to manage that, just like with your 401k. And there are some services out there, but unfortunately, it's not as well known. It's almost like it's the best well kept secret still. So more information's got to come out, and better disclosures need to happen so that people know what's available, what's out there, uh, because it's getting to be more and more of a problem, particularly as the baby boomers begin to retire, require more healthcare services, et cetera, et cetera. So I just want to go back to the shortage issue for a second here, as we're talking about different types of care and how do we get to care. What about the talent pool that's out there? When we start talking not only about physicians, either primary care or in the specialty areas, and other allied health professionals, what have you been seeing, Tamara, and your efforts around the talent pool issues?
So, what I've observed, what I've learned is that there just isn't enough outreach to a wide coalition of talent. So, I don't know if high schools still do this, but college fairs. I know when I was in high school many moons ago, there was a college fair, and different professions came out and introduced you to the ideas of different careers. But what I'll say is this: there has to be an expansion of the talent pool, and there has to be an increase in the number of seats and licenses. The AMA is very strict about the number of physicians that, they sort of let through the loop. But just to give you some numbers to think about. So 65% of providers of physicians in the US are white, and they're around 75% of the population. 18% of physicians are Asian, They're a little over 6% of the population. Hispanics are almost 20% of the population, but only 7% of physicians. Blacks, over 13% of the population, but they're less than 5%, or around roughly 5% of physicians. Your American Indian Native Alaskans are about 1% of the population and only slightly under 0.5% of physicians. Why aren't we reaching out to these communities? Why aren't we reaching out to rural communities? Why are we not, create? I think we need to make medicine and the allied professions more sexy, but we also need to make it more. Well, do you understand what I mean? I mean,
Yeah.
people,
More
everybody wants to
attractive.
be an influencer now. Not everybody
Yeah.
wants to be, they
Right, but
want
do
to be
people
a
want to go to
star.
school for 10 years? That's the, I
Right.
mean,
The
that's the other thing.
Right.
incentives.
The schools are doing something about that. They are making the program shorter. So instead of doing the 6 years, you're doing 4 years now and five in some cases. A lot of the universities their medical programs are low to no cost. So there are efforts being made to increase the physician population. A lot of physicians, instead of doing the MD route, are going into the DO route, the doctor of osteopathy. But that still counts towards the profession. So what I think we need to do is we need to. The once upon a time, there was a certain glow about becoming a provider, right? And what's happened is as salaries have decreased and burnout has increased and the paperwork burden and all these other things, it's taken the joy out of the profession and people are turned off. They don't see that as a viable profession because everybody's interested in work life balance. Not that they shouldn't be, but because of this whole idea of work life balance, when you think about physicians, that's one of the worst work life balances you can think of. And so nobody wants to do those positions. But you have to think of it differently. You have to think about the joy. Here's another interesting piece of information. A lot of physicians of color, they go into specialties. They can't become primary care physician because the salary is so low. They graduate to your point, Michael, you were talking about tuitions being so high. When they graduate, they can't become a primary care physician. They can't support themselves and pay off those, $500,000 in loans. They have to specialize, so they can't go back to their communities. So that's another problem that's happening. We need to invest in primary care physicians, not just on the college level, but we have to start getting young people to think about it on the high school level. And we need to incentivize in this country so that people don't graduate with all this debt. I know that's something they do in the European Union countries where they're not burdened with.
I think there's a couple things. It's not just about what you said. That's certainly a big piece of it, no question. But think about your experience, right? So if truly your primary care is your quarterback, you don't want to be bounced around, right? The patients don't want to be bounced around. It's bad. They already know I have to go see this particular doctor. So what's happened, I think, because you're going to get tossed to another provider, patients have gotten smart and said, "Well, I'm going to get a cardiologist. I'm going to get a dermatologist. I'm going to get an ortho, that I know from, because I get a referral from a friend who had a surgery or something like that." Because then you could just go seek those treatments yourself, right? To have a relationship with those individual providers. So I think to your point, primary care also needs to do a better job marketing themselves about why they're an important cog in the wheel, and like you said, make it sexy.
They're so overburdened though, Michael. They're so overburdened with paperwork. They can only see patients for maybe 10, 15 minutes. Where do they find the time? Where are they going to find the time to do that?
100%. I couldn't agree more. I'm just saying that they have to find a way to be more efficient and to be profitable and to be that single point of contact for the patient. I think they've lost that, right? To your point, because it's like, well, why do I need to go to a primary care if I can just go to my cardiologist to get a EKG? Like, what do I mean, I'm going to go to I want to go to the cardiologist anyway.
But it's going to cost more it's going to cost more to go to the cardiologist for that EKG than if you had simply done it as part of your annual visit with your primary care physician.
I think that that the part of engagement and being your own quarterback as a patient is part of this too.
That's a huge part of it. A huge part of it. Let's not downplay that. That's absolutely huge.
Yeah, ask questions, and this whole thing with "Make America Healthy Again," the Maha movement, and so forth. That I think really resonates a lot. I agree. Most of us end up with chronic conditions. So why are we going to a cardiologist who's really dealing with acute issues?
No, my point is if you need to do like a nuclear stress test once a year because you just want to know, like you don't care what your LDL is, you care what how your heart moves, how your valves are moving, right? Is it clear? Are there any blockages, right? That's what you care about because that LDL doesn't kill you. LDL is a marker, right? So you do that, and then you have that relationship, and then maybe you go twice a year or once every other year, whatever the case is. But the reality is that people have gotten educated and they've gotten access to these providers being able to just have a relationship. So that's why they skip over the primary care. It doesn't mean that's the right thing to do. It just means that's what's happening.
And it could, to Tamara's point, it ends up costing money, and there's a lot of people that can't afford it, or they don't have access to those specialists.
Yeah, that the most people can't afford to see a specialist. The best they can do is they can see your a PCP, an MP, a PA. That's what they can afford. And so let's say you go to an urgent care, you're not going to see a specialist. You're not going to see a cardiologist. You're not going to see even a necessarily a dermatologist. You're not going to see those kind of providers. You used to be able to see them, with the practice where, you had the primary care and the dermatologist and the gynecologist, and they all shared an office, and, they shared the load, and you saw, you sort of stayed with them as you grew, and a pediatrician. That model is gone. So the best now that you could maybe hope for is, and they're about as close to price transparency as you're going to get, because you literally walk up to the counter and you say, how much is this encounter going to cost? And they'll tell you $100 or $150, $75, whatever the cost. And okay, here's my card. I can afford to pay for that. But the average person, try going and doing that at a cardiologist. That's not going to fly. They're going to see you first, and then they're going to bill you afterwards, and then your eyes are going to pop out of your head because you can't afford the bill. But how many people do you know that go to a provider and ask,
They
oh, and
don't.
by the way, how much is this going to cost?
They
Right? They
don't.
don't.
They just
They
That's my
don't.
complain
point.
after. Yeah.
That's my
Right.
point. And you find out after, and that's why they created the No Surprises Act.
Right. But that's why it has to
Yeah.
change. Right. Yeah.
Yeah,
Yeah.
agreed.
So, since we're talking about what are things that we can be doing about change in healthcare and this consumer component, the other aspect we haven't touched on yet is really about the manufacturer and what's happening around manufacturing of products, the different therapies, not just drugs, but biologics, some of the digital technologies you could throw into that mix as well. So, what are some of the concerns around the shortages that we're seeing in drugs, and what manufacturers are now looking at with the tariff situation and so forth? Where are things at today?
So I think some of the problem, and you guys can probably speak to this better, is there's currently a drug shortage crisis. There are supply chain resiliency issues. There are supply chain vulnerabilities, right? The majority, and from my perspective, I think a lot of the problem is that the API, as you call it, the active pharmaceutical, is created overseas. Can we acknowledge that that may play a role in why we're having supply chain issues?
I mean, that's a part of it. Even before the tariff issue came in, there were a lot of supply chain problems with the quality of these active ingredients that go into making the pharmaceutical products, what they call the finished product. So similar to what we see with other industries with supply chain issues. We're so, I think, spoiled in the United States. We've been pretty sheltered from a lot of this, and now it's all coming out, and these shortages are getting worse, not only with brand name drugs, but also with generic drugs, We haven't seen it yet with biologics, but there are some periodic shortages, and most of it has to do with quality. So the active ingredients and the processing towards the final product, there's quality issues in these products because they're not easy to make. So absolutely, these intermediate or starting components that are active ingredients for the final product are an issue in the supply chain and is affecting shortages. It also, because there's shortages, affecting the price. And so that raises another whole problem, whether it's you're under insurance or not under insurance. Because if you can't get the product, no matter who you are, what you are, and how much money you have, that's a problem. So that's kind of what I've been seeing.
Are there particular therapeutic area or drugs that stand out that have the biggest shortages?
A lot of generics. And then I think in some of the specialty therapeutic areas where there's a shortage of a particular ingredient, so it slows production. And so instead of making maybe a monthly batch of a product, they only can make it once a quarter because they don't have enough ingredient, things like that. So in the more common conditions like cardiovascular, some of the products, once in a while, antibiotics is always a problem. Being able to make enough antibiotics. We also have a lack of manufacturing capacity for finished product. Again, antibiotics is a great example. We used to make antibiotics here in the U.S. It's rarely made in the U.S. anymore. So you have transit times to consider. They have to ship it over, whether it's air freight or cargo ships. So there's time elements in this as well. And then if it's not worth it at the end of the day to the manufacturer to pay the increased costs of the supply chain, they get out of that part of the business or they sell it to somebody else. So there's a lot of economic factors that are kind of eating away at this. And so we're getting away as healthcare really being beneficial to the health of consumers to it's if I can't make money, I'm not going to do it. And I don't really care about the consumer. And it's unfortunate we've gotten to that, but that's where we're at.
There's also the shortage of pharma talent. I mean, at one point, we were importing a lot of that talent, and I don't know that we're doing that anymore. I mean, certainly it's not homegrown.
Well, it's kind of akin to what we're talking about with the provider shortage. So within the pharmaceutical technology arena, there are shortages of people going into that part of the business because it's a small niche. Requires a lot of education. You go through the same same kind of issues that we talked about with providers. They can make more money than physicians, ironically, but that's not as many as there used to be. We've also changed how we test drugs. So a lot of testing of drugs is not done in the U.S. because it's way too expensive in the U.S. So it's in other parts of the world where a lot of the new drug testing happens, and it's very expensive to get a drug approved through the Food and Drug Administration or FDA in the United States. So again, we're back to a lot of these economic issues are putting pressure on the health care issues and how do we take care of patients.
Yeah, I mean, you have to get to common sense. I mean, everything that's happened is so out of control. I mean, why do universities get billions of dollars in grant money when they have billions of dollars in endowments? Like, why? Why are they accepting certain students over another? And why aren't they giving everybody a fair shot? Right? If that's the idea, is to give everybody a fair shot. So there's a lot of common sense, right? So you can but most of it's following those dollars, right? Because again, the health plans should not be, they are not good stewards of our healthcare dollars. They are no longer good stewards of that. So that has to change, right? And those are huge dollars.
Yeah, as we had more and more vertical integration, so to speak, where they're buying up in more of a vertical as well as a horizontal way, and to grow their business, they got away from their primary purpose, and we see that over and over again. PBMs in particular is a great example, and going back to when they started in the '60s and '70s to help Medicaid, it was great, and then very quickly it evolved to the problem that we have today, which is just getting worse and worse by the day.
So, Tamara, I'll give you an example. We also have pharmaceutical clients in my consulting practice. And we were with a client in a state. I can't say the state because you'll know who they are. But anyway, they were a drug manufacturer who was launching a drug in a crowded market. So there's generics, there's other brands. So they have to be competitively priced, right? because you're launching a new product, you want to sell it. If you overprice it, you're not going to get sales, right? So the CEO wanted to make $200 a month on every script, which is, for that market, for what it is, very reasonable when you think about it. But in order to make $200, guess how much he had to charge?
400.
600, 1,000,
$1,200
Oh,
$1,200.
wow.
Wow.
because he had to give a 70% discount to the PBM for them to cover it.
Wow.
So now the
That's outrageous.
right, so the PBM now makes 70% of the drug cost, and the drug company only makes 30. And then guess who's paying that? The patient or the health or the employer.
The employers have been as bad as consumers, and I have to say, one of the things I'm involved with is the employer provider council, which gets into a lot of this set of issues that we've been talking about. But this lack of collaboration and understanding between manufacturers and employers, because employers could make a difference and stop a lot of these shenanigans, but they have been allowing it to go forward for decades now. So employers have got to get engaged.
So what I love about what we learned from the conversation with the Health Rosetta team was they bring things very down to basic, which I think is really smart. And he said every business has a procurement department, right? So if you're a deli and you make sandwiches, you're buying, you know what you have to pay for the bread, the meat, the condiments, all that stuff in order to sell it for a profit, right? But you look at those pennies, you count those pennies to make sure you can make money. Nobody looks at healthcare like that. And you can look at healthcare as a procured service, right? So you can establish a relationship with a local hospital system, establish relationships with providers, establish relationships with pharmacies, and say, hey, I've got 100 employees and we're going to do all of our care through you, but this is what we're going to pay for it. And these are the services, these are the prices, and then when it comes in, I'm going to check that bill against what it should be. And there's no discounts, and we'll negotiate, but I'm going to pay $100 for the MRI or $500 or whatever the negotiation. That's fine, but I'm not going to pay $8,000 for it. When you send that bill in, and it's just common sense.
Right. But the question is, does that remove the PBM
Yes,
from
thank God.
how? Well, how?
Yeah.
But how
Well,
does it
well,
remove them?
well, you got to look at there's a set of services that a PBM provides, but there's
Okay.
also lots of other things that happen behind the scene that you can disintermediate that PBM. So if you change the system, and that's part of what we see beginning to take hold within Medicare, we're going to see it in Medicaid, but commercial's got to do the same thing. Commercial insured plans where employers operate, which also includes state government, by the way, is commercial insured lives. So and unions is another one. So they have to be looking at this more critically, like procurement, and there have been a lot of success stories. So it's very doable. And commercial, you don't have a lot of the restrictions that you have within these government programs. So you have to go through Congress and all this stuff. So they can make a change within a year.
Well, there's still lots of laws around commercial health plans.
Yeah, but a lot of that's starting to go away, and there's lack of interest on enforcement on a lot of this stuff now. But you're right. We have to look at what has not been taken advantage of that can be done. And under ERISA, which is the way the commercial plans operate, if you're self funded, there's a lot of latitude in there. But nobody understands it who works in that employer side because they haven't paid attention to it. So again, this kind of issue that we're trying to deal with through our employer provider council activities is get them to understand what they can do. It's called fiduciary responsibility. And also look at with manufacturers, here's an opportunity how you can work differently and bypass a lot of the ways in which you've been doing things now. We are seeing some efforts by manufacturers on what they call direct to patient or direct to consumer types activities, but that only really is a small sliver of the market and usually in specialized areas.
But I think that's going to grow. I think I see that push happening, and I think that number is going to grow over time. What about digital tools? Are there any digital tools on the horizon to address this? tracking the shortage, anticipating the shortage, heading off the shortage? Are there any tools that you're aware of on the horizon for that?
Yeah, there's some of that going on. Some of the professional organizations, as well as manufacturers, have been tracking, and they're trying to do a better job. AI is helpful to a certain extent, but a lot of these things are unknown until it's too late, and it's this negative chain that happens once you miss one thing, and it may not have been predictable. So there's a lot of lack of predictability in healthcare, unfortunately, and one of them is in this drug supply chain as an example. So they're trying to make a better effort to get a handle on that.
Going back to what Michael was saying about the procurement, is there not a procurement type process for, okay, we have, all these parts that need to come together to make this drug and bring it to market? So that doesn't exist, you're saying?
No. Well, the procurement process right now is they use brokers, right? So they say, "Oh, my healthcare is going up 20% a year. Can you help me reduce my costs?" Then the broker comes in and says, "Oh yeah, let me take a look." Then they go through the same, it's all the same, right? So they go through their same process. "Oh yeah, I can save you 10%, or I can save you 20%, or whatever." Then they win then they win the business, but it's the same thing. They lower your premium to get the business, and then they're going to jack you up anyway. But again, it's the premium. To me, the premium is what is the fear that is put into decision makers to say, if you don't pay this premium and you have a big claim, you're going to go out of business. So they then it's just like, okay, I trust you. I don't want to. And then they tell them all the horror stories about what happened versus the success stories, like what Randy was mentioning earlier, where what is it? What did he save this chain? Like $550 million over 10 years in healthcare spend. Because they actually did away with the whole kit and caboodle, and they purchased healthcare themselves. And then even with that cost savings, they paid for all of their employees' kids' college. So they created new programs, incentives to keep their employees as employees and incentivize them for other major life events that they could pay for because they saved all that money in healthcare.
So this is probably a good place to stop. We've covered a lot around the shortages within the healthcare world, how we need to see better engagement, certainly need to see system change that's more beneficial to the consumer. And with that, we'll close out this version of the Only Healthcare episode podcast on what's happening with consumer access. Thank you for joining us, and please follow us and check out the next episodes of the Only Healthcare podcast.
Thank you for tuning in to the Only Healthcare podcast. We hope you found today's episode insightful and informative. Remember, our mission is to provide actionable and inspirational insights on how we can improve healthcare cost, care, and accessibility for all. If you enjoyed this episode, please subscribe, rate, and share with your friends and family. For more resources and updates, visit us at onlyhealthcarepodcast.com. We'd love to hear from you. Let us know what topics you'd like us to discuss in future episodes. Until next time, stay informed, and together, let's navigate the journey to better healthcare.